Today we shall be discussing one very important topic, the staging of breast cancer. Now, the staging of breast cancer sometimes becomes very confusing, especially the new incorporation of AJCC. This is very important not only for your entrance examination but also for your final MB examination, DNB MS final examination, as well as the super specialty final examinations. Now, to start with, we need to be familiar with a few terminologies. For the any staging includes these three things: T, N, and M. All right. The T stands for the tumor size, the N stands for the lymph node, and M stands for the metastasis, the status of metastasis. Now, there are two types of staging included in AJCC. One is CTNM, another one is PTNM. Now, this CTNM means when you diagnose the patient clinically. This clinical thing includes clinical examination, all sorts of radiological examination except lymphoscintigraphy. So remember, a patient who is having a breast lump of 5 centimeter detected in MRI is included in clinical staging. All right. Whereas pathological staging means after you operate on the patient, and the final staging in the pathological specimen is known as PTNM. Now, there are two another important terminologies. One is Y. If you add Y before CTNM or PTNM, that means this staging is after the neoadjuvant chemotherapy. So, at the very beginning, you stage the patient. After you put the patient on neoadjuvant chemotherapy, then you re-evaluate the patient, and finally, when you operate, after operation, if you get a TNM, that is known as YTNM. So, Y stands for a post neoadjuvant status. All right. Now, regarding N, nowadays there is something called SLNB, sentinel lymph node biopsy. So, if you diagnose the nodal status based on SLNB, then you add SN. So, it's like N0 SN. Okay, so this SN stands for sentinel node biopsy. You have detected it by doing a sentinel node biopsy. When you detect the nodal status based on FNAC, there you write F. So N1F. All right. This is how the AJCC staging procedure works. Now let us look at the T staging. Okay, this T staging is very important. Now, two important points here are they have included carcinoma in situ, the ductal carcinoma in situ, and the Paget's disease. So remember, LCIS, lobular carcinoma in situ, is no longer a part of breast cancer. So this is taken as a pre-cancerous stage. Okay, so DCIS and Paget's disease, they are included in carcinoma in situ, but LCIS or lobular carcinoma in situ is no longer taken as a cancer. It is taken as a pre-cancerous lesion. Now, if we look at the different T staging, then how do you remember? Remember, there are T1, T2, T3, as well as T4. Okay, T4 is again divided into A, B, C, and D. Now, this T1, 2, 3, they are based on the size criteria. Okay, they are based on the size criteria. How do you remember? Remember T2. So 2, 2, 2, 5. All right. So you just need to remember this 2. Okay, so T2 is 2 to 5. So obviously T1 will be less than 2 and T3 will be more than 5. So T2 is anything between 2 to 5. So 2 less than 5. Now remember, here one important point is you will have equal to with the lesser one. So 2 less than equal to 2 less than equal to 5. That means a 2 centimeter lesion is T1, whereas a 5 centimeter lesion is T2, not T3. So to be designated as a T3, it has to be more than 5 centimeter. Am I clear? So remember 1, 2, 3, T1, T2, T3. T1 is less than 2 centimeter. You remember 2. So 2 is 2 to 5. So more than 2, less than 5. And you add less than equal to only with the lesser ones. Okay. So it is not more than equal to. It is always only more than. Okay. So less than 2, 2 to 5, less than 5, and more than 5. Okay. Now T4 A, B, C, D. How do you remember? You just remember the breast. Okay, so this is the chest wall. This is the chest wall. These are the ribs. All right, and this is the breast. So you remember from inside outwards. From inside outwards. So T4A means when the tumor has invaded the chest wall. Tumor has invaded the chest wall. C. Okay, so inside outwards, first the chest wall, then the breast, then the skin of the breast, then the whole of the breast. Okay, so T4A is the chest wall invasion. Now remember, this chest wall invasion means involvement of the ribs, involvement of the serratus, involvement of the intercostal muscles. So by mere involvement of pectoralis major doesn't alter the staging of breast cancer. So pectoralis major involvement will not have any effect on the staging. Okay, so chest wall means the ribs, the intercostal muscles, and the serratus anterior. So T4A means chest wall. Okay, so you start from behind, andar se bahar. So you start from behind, then you go anteriorly. So chest wall is T4A. T4B is skin involvement. Skin involvement. Okay, skin involvement. Now, what type of skin involvement? You remember ulceration, satellite nodule, and edema or pudy orange. I remember it as USP. USP. So, if the skin has ulceration, satellite nodule, so multiple nodules, or pode orange or pudy orange, which is called orange peel appearance. So this is nothing but the edema of the skin of the breast due to the blockade of the subdermal lymphatic plexus. Okay, so andar se bahar, chest wall involvement T4A, skin involvement in the form of ulceration, satellite nodule, or pudy orange is T4B. T4C is both. So when you have both chest wall as well as the skin involvement, it is called T4C. Now, the skin, when it involved, the skin is erythematous and the 1/3 of the skin is involved, the special variety of breast cancer is known as inflammatory cancer. Inflammatory cancer or mastitis carcinomatosa. This special variety is so dangerous. That is why whatever the size is, it is directly taken as T4D. Okay, so chest wall, breast skin, the both, and the whole of the breast, or the at least 1/3, more than 1/3 of the breast involvement in the form of inflammatory carcinoma. Okay, so T4A is chest wall, T4B is the skin of the breast, T4C is both, and T4D is an inflammatory carcinoma. Now, how do you understand this is inflammatory carcinoma? There is more than 1/3 of the breast which is involved by an erythematous or inflammatory lesion. It looks like a breast abscess. Okay, in most of the cases you end up doing a skin biopsy to diagnose this case. Okay, so just to revise, T1 means less than 2 centimeter. How do you remember? You remember 1, 2, 3. 2 stands for 2, 2 to 5. So this is the only number you need to remember, 2 to 5. Okay, and always remember there is no more than equal to, there is only less than equal to. Okay, so 2 to 5. less than 2 and more than 5. So you add equal to with the lesser one. Okay, so less than equal to 2, less than equal to 5. So that's how you remember. And regarding the T4, you remember andar se bahar. So chest wall is T4A, skin is T4B, both is T4C, and inflammatory carcinoma is T4D. Now let us come to the N status. N stands for the lymph node. Okay, N stands for the lymph node. Now N is divided into N0, N1, N2 and N3. Okay, again in N you have a clinical N status, you have a pathological N status. The pathological N status is very easy. It is based on the mostly the number of lymph nodes, but clinical lymph nodal status often becomes confusing. So let us see what are the lymph node areas which are involved, and if you remember this way, then it's becomes very easy to remember. So from breast, most of the 80% of the breast lymphatics, they will drain into axillary lymph node. Okay, so this is one, axillary. If the tumor is located medially, where will it go? It will go in the internal mammary group of lymph nodes. Internal mammary group of lymph nodes. Okay. Now there are two group of lymph nodes based on the clavicle. One is supraclavicular, one is infraclavicular. So which one is first? Obviously the infraclavicular. This is nothing but the level 3 lymph node. You know, based on the pectoralis minor, we divide the axillary lymph nodes into three groups. One is the level 1, which is lateral to the lateral border of pect minor. Level 2 is the lymph nodes which are deep to the pect minor, and level 3 are those which are medial to the medial border of the pect minor. So if we remember these four group of lymph nodes, then the clinical staging of lymph node, axillary lymph node, becomes very easy. So first is the axillary, because breast drains into axilla. If the tumor is located medially, then it will go to the internal mammary group. Then if from the level 2 of axillary, it will go to the infraclavicular group, and from there finally it will go to the supraclavicular group. All right, now let us see how the N status is taken. So N1, N2 and N3. I told you what are the groups: axillary group, internal mammary group, infraclavicular group and supraclavicular group. Okay, so N2 again divided into 2A and 2B. N3 is divided into A, B and C. Okay, now how do you remember? The first group where it goes, we all know, is axillary. So remember, ipsilateral, axillary, mobile lymph node. So from breast, where it will go? It will go to axillary. So N1 is ipsilateral axillary. N2 is also same, ipsilateral axillary. So how do you remember? You remember axillary in N1 as well as in N2. Now what is the difference between the N1 and N2A? Both are axillary. Here in N1 group, the lymph nodes are mobile. So when you palpate, you see they are mobile. But in N2A, it is either matted or fixed. Now what is matting? What is fixity? When two lymph nodes are, or multiple lymph nodes are joined with each other, we call it matted lymph nodes. Okay, when the lymph node, one single lymph node or two lymph nodes, is attached to nearby structures, it is called fixity. So N2A means same axillary lymph nodes, but they are either matted or fixed. Am I clear? So this axillary group of lymph nodes will give you N1 as well as N2A. Am I clear? So N1 as well as N2A, they are both for axillary. N1A, N1 means axillary mobile, N2A means axillary fixed or matted. Clear? Fixed or matted. So that is N1 and N2A. N2B means internal mammary group of lymph nodes. So there comes the N2B. Okay, clear? Now we are left with N3. N3A and N3C. You remember N3A, what are the groups we are left with? We are left with infraclavicular and supraclavicular. Okay, now from axilla, the first from breast, the first they went to axilla, second they went to internal mammary group. Now they will go where? Infraclavicular or supraclavicular? They will go to infraclavicular first. So N3A is infraclavicular and N3C is supraclavicular. Clear? So that's how you should remember. Now, if the patient has a central location tumor or a big tumor, that tumor can go both in the axilla as well as in the internal mammary group of lymph nodes. So this N2B, N3B is both N2A plus N2B. So both axillary and internal mammary group of lymph nodes. Okay. So just to revise, we have 4 group of lymph nodes in axilla in relation to breast. One is axillary group of lymph node. We divide the axillary group of lymph node again into two parts based on fixity or mobility. One is mobile, another one is matted or fixed. Okay. Then we have internal mammary group of chain of lymph nodes. We have infraclavicular and supraclavicular. So N1 means ipsilateral axillary mobile. N2A means ipsilateral axillary fixed or matted. Clear? N2B means ipsilateral internal mammary. From there, where it will go? It will first go to infraclavicular. So it is N3A. And the final destination is where? Final destination is supraclavicular. That is N3C. And N3B is equivalent to 2A and 2B. That means both internal mammary as well as axillary. So that's how you should remember the nodal status of axilla in relation to breast cancer. So this is just to demonstrate. You have a tumor here. From there it will go to the axillary. If it is mobile, so you see it is moving, then it is N1. Okay, if it is fixed or matted, we call it N2A. So this is matting or fixity. Okay, N2B means when you have internal mammary but in absence of axillary, it is called N2B. Clear? Now N3A is axillary plus infraclavicular, as I told you. N3B means both axillary as well as internal mammary, and N3C is the final destination, that is supraclavicular. Okay, so these are the clinical staging of lymph node in relation to breast cancer. Now remember one very important point: if you have an opposite axillary lymph node, then what it is? All these staging N1, N2, N3, they are for ipsilateral axilla. If you have opposite axillary lesion, then there are two possibilities. One, it is an M1 disease, metastatic disease. From this breast it has gone to that axilla, so it is a distant metastasis. Another possibility is you have an occult cancer in the opposite breast. You need to pick it up. Okay, from there it has gone there. So if you get an opposite axillary lymph node, it is either a metastatic or M1, or you have another occult lesion in the breast, in the opposite breast, which you are yet to discover. All right. Now the pathological staging, they have now included in N0 two important points. Just to remember that N0 is no longer N0. You might get some smaller, very smaller tumor cells. They are so small, you see, they are less than 0.2 millimeter, or you get isolated tumor cells in the lymph node. These are specially detected in the setting of sentinel node biopsy. So there you call it I positive. Okay, so I positive. And if you detect them in molecular testing by doing RT-PCR, we call it mol positive. So N0 N0 is pathological N0. When the pathologist sections the lymph node in detail, they might find a positive molecular metastasis there in the lymph node. Then it is called MOL positive. But these are not clinically so significant. Okay, the management will not change, especially after the results of ACOSOC Z11 study is there. Now, this is a clumsy slide where you see the pathological staging, but what you need to remember is very easy. You remember pathological N1 1 to 3 nodes, pathological N2 4 to 9 nodes, and pathological N2 N3 is more than 10 nodes. Okay, so that's how you need to remember the staging of breast cancer. One important point now the AJCC has included is the grade of the tumor. So they are divided into grade cannot be assessed: GX, G1, G2, and G3. Okay, so these are based on some criterias which are seen in the tumor. Okay, how do you remember? You remember as TNM again. Okay, and this whole thing was devised by Scarf Bloom Richardson, so it is also known as SBR, and it was modified by Nottingham, so it is called Nottingham's modification of SBR system. Okay, now this grading system is done based on TNM. T stands for tubule formation. Alright, N stands for nuclear pleomorphism, and M stands for mitotic count in the cell, in the cancer cell. Am I clear? So tubule formation, nuclear pleomorphism, and mitotic count, they are graded as 1 to 3. So what is the minimum count? You have 3 parameters, one of each, so 3 to 9 is the total score. Am I clear? So GX means when you cannot assess the grade, cannot assess the grade. G1 means when you have 3 to 5, this score based on this TNM, tubule formation, nuclear pleomorphism, and mitotic count. So 3 to 5. All right, then 6 to 7 and 8 to 9. Clear? So when you get a breast cancer with grade 8 or SBR 8, that means it is a high grade tumor. So this grading system is now also included in the AJCC staging protocol. So how do you remember? You might get MCQ based on which features this grading system is done. It is based on tubule formation, nuclear pleomorphism, and mitotic count. You remember as TNM. Okay, so just to recapitulate, when you have a breast cancer diagnosed, you need to stage the disease, and I have told you how to diagnose it, how to stage them properly. Okay, and T1, T2, T3, T4, you remember the 2 and 5, these numbers only, and always add equal to with the lesser one, not the greater one. Okay, so T1 is less than 2, T2 is 2 to 5, okay, and T3 is more than 5. You add equal to with the lesser one. Regarding the T4, you start from andar se bahar. That means T4A is chest wall, T4B is skin in the form of ulceration, satellite nodule, or edema or pudy orange. I remember it as USP, ulceration, satellite nodule, and pod orange. Okay, so that is how you remember breast cancer staging. Okay, thank you very much.